Hello, my name is Olexiy Pukhov, and I'm currently a pharmacy student at the University of Toronto. Recently, I did a presentation to the faculty for one of my rotations regarding vitamin K2, which is a topic that I'm very interested in. Now, the presentation turned out to be very well, so I want more people to be educated about this topic if they can. This presentation does have a lot of scientific information, so it's more geared towards doctors, pharmacists, or perhaps researchers. But even if you don't fall inside the intended audience, that's okay because I tried to make this information very digestible and easy to follow. So, with that being said, I will begin the presentation now. So when you get a blood injury, when you get a puncture injury, and you have some blood comes out and then it stops, that is called coagulation. And for a very long time, we've known that vitamin K is essential in coagulation. However, if you mention vitamin K to any pharmacist or to anyone in the healthcare field, they almost always think of vitamin K1 because that's the vitamin that we've always thought of is the only one in vitamin K. However, recently vitamin K2 has also come to light. And would you ever imagine that in a dish such as this, that it is chock full of vitamin K2? Well, later on in the presentation, I'll actually explain why in a dish such as this, there's actually is a lot of vitamin K2. And this new vitamin that we've discovered, vitamin K2, actually has has a role in bone mineral density and bone mineral content, has a role in the cardiovascular system, has a role in blood vessels, and also recent evidence, recent research is very interesting, but it's kind of a small study. Is that it might even reduce mortality due to COVID-19. So, the learning objectives for this presentation are to describe the different functions of vitamin K2, to describe where K1 versus K2 is found, and just how prevalent K2 deficiency is in our Western society. I want you to explain K2's method of action and how it can be useful in bone mineral density, cardiovascular disease, and perhaps even COVID. I want you to understand when K2 is appropriate and when it is contraindicated. And perhaps you might even be able to find a way to apply this in your own practice after learning about this information. So I'll begin. Vitamin K was first discovered almost a century ago with an essential role in coagulation. Since then, vitamin K has been found to have many different isoforms. The prime players here are phyloquinone, also known as vitamin K1, and menaquinones, also known as vitamin K2. Vitamin K2 can be further subdivided into various isoforms such as MK4, MK7, MK8, and MK9. MK4 and MK7 are the isoforms known to have positive biological effects. Vitamin K2 also has very different roles than vitamin K1. However, vitamin K2 is rarely used in the Western world. Emerging evidence is coming out on the potential use of vitamin K2 on a host of different indications. However, once again, most people are unaware of the effects of vitamin K2 and how they are very different than vitamin K1. This can be the reason that vitamin K2 has such a different role than vitamin K1 can be traced back to its extrahepatic activity, to the reason to which will be explained later in the presentation. Now, since a lot of pharmacists are actually listening to this presentation, you might be wondering, the vitamin K that we use for warfarin-related coagulopathy, does it contain vitamin K2? Well, I was interested in this very same question, and I actually looked it up. And the American Heart Association actually recommends that K1 should be used for warfarin-related coagulopathy. So the vitamin K that's used in hospitals, that's entirely K1. However, in Japan, this is actually different. In Japan, K2 is used instead for this warfarin-related coagulopathy. So it's very interesting how different countries have actually done different things. So, where are they found? Well, different foods contain vitamin K1 and vitamin K2, known as MK7. Vitamin K1 can be found in leafy green vegetables. The greener, the better. These are foods such as spinach, kale, and Swiss chard, but that is not the same place that vitamin K2 is found. Vitamin K2 is primarily produced by bacteria, so it is found in high concentrations in fermented foods such as pickled vegetables and cheeses. However, the Japanese have a food with very high concentrations of vitamin K2 known as natto. Remember that picture that I showed you near the beginning of the presentation? Japanese have been consuming natto for thousands of years, and it is a staple of a Japanese breakfast. The Japanese breakfast is usually with eggs on rice, known as tamago kaku gohan, or also including natto, known as natto tamago kaku gohan. This is the image that I showed you near the beginning of the presentation once again. This is a table showing you the structure and the other characteristics about the three major forms of vitamin K. K1, K2 is MK4, and K2 is MK7. There are a couple of things to look at on this slide. Firstly, look at how the structure between all three forms are different. As you can see, vitamin K1 has a short tail that is almost entirely saturated. Vitamin K2 has the same length of tail as vitamin K1. However, it has double bonds in its structure. Vitamin K2 as MK7 has a longer tail than either vitamin K2 or vitamin K1 as MK4. However, and also it has more double bonds as well than either vitamin K2 as MK4 or vitamin K1. This is reflected in the half-life, where vitamin K1 has a half-life of 3 hours, vitamin K2's MK4 has a half-life of 1.5 hours, and vitamin K2's MK7 has an outstanding long half-life of 70 hours. This long half-life allows it to have long duration of action and extend more positive effects than the other form. Therefore, most of the research focuses on vitamin K2 as MK7, since it is the form with the best bang for your buck, so to speak. Furthermore, it also possesses extrahepatic activity, which means activity outside the liver, that MK4 and K1 do not have. This is why for the rest of the presentation, I will be mostly focusing on vitamin K2 as MK7. Now, K2 has actually recently been found to have positive effects in bone mineral density for osteoporosis. It's also been found to have cardiovascular risk reduction, and it might even potentially reduce mortality due to COVID-19. So, how's worldwide consumption of this important vitamin? Well, in a relatively recent study, 97% of people surveyed had a vitamin K2 deficiency or insufficiency. On the worldwide levels of vitamin K2 consumption, the Western world is deficient of vitamin K2. Furthermore, vitamin K2 is a vitamin that is not well known in the Western world. It is interesting to note that many cultures around the world have fermented foods, such as Asian cultures, Indian cultures, and Russian cultures. Just think of kimchi from Korea, for example. However, these foods are an order of magnitude away from the content of vitamin K2 that is found in natto. So this is a table showing you the different content of vitamin K2 containing foods. The different subtypes are listed, and if you look at the MK7 content in natto, it's just off the charts. Look at it; it's 999. It's just maxing out the chart, and when you compare it to the MK7 content of food that other cultures have, such as sauerkraut, it's an order of magnitude difference away. Furthermore, vitamin K2 is produced by bacteria during fermentation, so you can see it in cheeses such as blue cheeses, just cheddar, and the hard cheeses and soft cheeses as well. Now, why does it act so differently? Well, the reason that it acts so differently is because of the extrahepatic activity that is unique to isoforms MK7, MK8, and MK9. MK7 is a principal player here because it offers beneficial effects and has been studied more than MK8 or MK9. However, to understand the reason it has extrahepatic activity, you have to understand how it is absorbed first. So, when you consume vitamin K2, it is emulsified by bile salts and is taken up in the small intestine by the enterocytes. Now, depending on which isoform of vitamin K2 you ingest, they also have different absorption and different bioavailability. If you look at the percent absorbed of MK7, it's around 40%. But if you look at the extrahepatic activity of MK7, it's 70%. It's very, very high for extrahepatic activity, and it is high for absorption as well. So vitamin K2 is better absorbed than vitamin K1, and MK7 is an isoform of vitamin K2 that has the greatest absorption and bioavailability. Vitamin K is then taken up by the enterocytes and packaged into chylomicrons. Lipoprotein lipase then acts on these chylomicrons, and it is then transported to the liver. In the liver, vitamin K1 and vitamin K2 absorption diverges here. Vitamin K1 is preferentially retained and it is rapidly excreted, while vitamin K2 acts within the liver and is then transported into the circulation using LDL. This allows it to have extrahepatic activity. Again, this means activity outside the liver and effects all over the body because it is transported outside of the liver using this LDL. Now, how does vitamin K2 actually work? So this is an important slide to understand the rest of the presentation. So vitamin K2's main action is to mediate vitamin K carboxylation. Carboxylation. So it carboxylates, therefore activating two proteins known as matrix GLA protein from the uncarboxylated state, known as UCMGP, to their carboxylated state, CMGP. It also activates osteocalcin from the uncarboxylated state, UCOC, to the carboxylated state, COC. So this activated CMGP is found in blood vessels and counteracts vascular calcification and age-related wear and tear. Osteocalcin helps to bind calcium into the bones, and osteocalcin is produced by 125 dihydroxy vitamin D3 in the inactive form, UCOC. So the activation is controlled by vitamin K2, which carboxylates osteocalcin into the carboxylate form, COC. COC helps to incorporate calcium into the bone matrix using osteoblasts. So now let's go over this diagram. So when you ingest vitamin K in the form of menaquinones, remember we had phyloquinones, which were vitamin K1, and menaquinones, which were vitamin K2. It activates two proteins, which are matrix GLA protein and osteocalcin. Now, matrix GLA protein is found on blood vessels, and osteocalcin is found inside the bone. They have different actions. Matrix GLA protein is carboxylated by vitamin K2 from UCMGP to CMGP, and this leads to the inhibition of vascular calcification because this protein is found on the surfaces of blood vessels. Now, it also carboxylates UCOC to COC, and therefore it leads to the promotion of bone mineralization. So this is all very interesting, but does it actually work? So in order for us to evaluate this, we have to look at some clinical trials for efficacy. So in this efficacy for bone health, there's a February 2013 randomized controlled study in Limburg, the Netherlands. And this was in 244 healthy menopausal women aged 55 to 65 years. They were treated with MK7, 180 mcg per day for 3 years, and they were compared to placebo for 3 years. And the researchers were trying to find if this influenced the UCOC, COC, or bone mineral density at the femoral and lumbar and hip. So this is what the researchers found. So if you look at the white, this represents the MK7 treatment group, and the black represents the placebo group. So let's go over the first figure. So this is regards to UCOC and COC. So you see over a 3-year treatment duration. So if they were taking MK7, vitamin K2, then their UCOC level decreased. And over the treatment duration, their COC level increased. And this makes sense because vitamin K2 status is, you can tell vitamin K2 status by the UCOC levels and the COC levels. As your vitamin K2 status improves, for example, through MK7 supplementation, then your UCOC level would decrease and your COC level would increase. So for example, let's now look at the bone mineral content at the femoral neck and also look at the bone mineral density at the femoral neck. So as you can see, in both groups, over the treatment duration, which was 3 years, they both decreased. However, if you look at the MK7 treated group, it decreased less than the placebo group for the bone mineral density and the bone mineral content at the femoral neck. So this suggests that there is some kind of protective action by vitamin K2 as MK7 on the bones, and thereby reducing the amount of bone mineral density and bone mineral content that you lose for just to aging relative to taking nothing for it. So now let's look at the bone mineral content and the bone mineral density at the lumbar spine for the treatment duration, which once again was 3 years. As you can see, once again, both groups, they both decreased over the treatment duration. However, if you look at the white dots, which are the vitamin K2's MK7 group, they decreased less than the placebo group, which wasn't taking anything during the 3-year duration. Oh, sorry, not taking anything is a misnomer. By that I mean they were taking a placebo, and the placebo might be a pill, but it actually has no biological effect. So, so it did not have any effect on the bone mineral density or bone mineral content, but the vitamin K2 with MK7 group, they had their bone mineral density, bone mineral content decrease less than placebo. So furthermore, the researchers also included another type of statistics. This was the compression score index and the impact score index. And once again, in both groups, they decreased throughout the treatment duration, which was 3 years. However, once again, the vitamin K2's MK7 supplemented group decreased less than the placebo group, suggesting a protective effect of vitamin K2 on the bones. So now let's look at the efficacy on the cardiovascular system. So this comes from a 2004 prospective population-based study in Rotterdam, the Netherlands. 4,807 people with dietary data and no history of MI at baseline, and their vitamin K1 and K2 intakes were recorded over a follow-up period of around 10 years, from 1990 to 1993, and this was followed until 2000. And they wanted to see if either your vitamin K1 intake or your vitamin K2 intake predicted coronary events, all-cause mortality, and calcification events. So what did they find? Well, they found that when they compared the group that was consuming the least amount of K1 to the group that was comparing the highest amount of K1, there was no association. However, when you compared the group that was intaking the least amount of K2 to the highest amount of K2, there was less cardiovascular death, and there was less all-cause death and less coronary heart death as well. And then if you look at the group for from low K2 to high intake of K2, it did not affect the moderate calcification event, but it's dramatically reduced severe calcification events. So now let's look at the data. So this is the data that they have, and this is for the association of coronary events and all-cause mortality with intake of phylloquinone. Remember, this is vitamin K1 and not K2. So in Dutch men and women or age 55 and over. So we have non-fatal myocardial infarction, heart attacks. We have incidence, coronary heart death. We have coronary heart death mortality and all-cause mortality. And this is the group with the least amount of intake of phylloquinone intake, so the least amount of K1. And this is the group with the highest amount of K1. So now if we compare the number of MI events from the low K1 group to the high K1 group, we can see that there was 48 in the low K1 group and there were 40 in the high K1 group. And then when doing statistical analysis, this wasn't significant. When we compare this same amount to the number of new coronary heart death events, coronary heart death mortality, or all-cause mortality, this is all non-significant. So vitamin K1 has no association. So this is the researchers' table 3, and it's the association of coronary events and all-cause mortality with intake of menaquinone, or vitamin K2, in 4,807 Dutch men and women aged 55 and over. Once again, this is the low group, lowest intake of vitamin K2, and this is the group with the highest intake of vitamin K2. And now, if we look at the number of MI events, the number of new coronary heart death, coronary heart disease, new coronary heart disease, coronary heart death mortality, and all-cause mortality, we can see that in the number of MI events, there was no significance. But if we look at the number of coronary heart disease new events, there were 86 in the low K2 group and 56 in the high K2 group. So this was statistically significant. If we also look at coronary heart disease mortality, there were 41 in the low K2 group, and there were 23 in the high K2 group. So this, again, was statistically significant. And if you also look at all-cause mortality, there were 258 in the low K2 group, and there are 195 in the K2 in the highest K2 group. So once again, this was statistically significant. So we are finding that if compared to the lowest K2 group and the highest K2 group, so it was statistically significant that K2 reduced the number of new coronary heart disease episodes. It decreased death from coronary heart disease, and it even decreased all-cause mortality. So this is table 4 that the researchers included, and this is aortic calcification with intake of vitamin K2 in 4,473 Dutch men and women aged 55 years and over. And they compared the lowest K2 intake group to the highest K2 intake group for moderate calcification and severe calcification events. So if we look at the number in the lowest K2 group for moderate calcification events, it was 454. And if we look at the number in the highest K2 intake group for the number of moderate calcification events, it was 453. And this wasn't significant. But if we then look at the severe calcification cases, there were 98 in the low K2 group, but only 59 in the high K2 group. So this was very statistically significant, suggesting a role of vitamin K2 for the protection of the arteries against calcification. So, but this was just a prospective study. Are there any actual clinical trials for vitamin K2 on the blood vessels? Well, in June 2020, there was a randomized placebo-controlled trial on vascular elasticity in healthy subjects in Maastricht, Netherlands. And the population was in 243 subjects, 40 to 70 years old. They, with a UC-MGP level higher than the median of the general population, did 180 mcg of vitamin K2 as MK7 daily given for 1 year compared to their baseline characteristics and the placebo group pre and post 1 year, exert positive favorable effects on vascular characteristics. And in this case, they used the carotid femoral pulse wave velocity. So just what is this carotid femoral pulse wave velocity? Well, it's considered the gold standard of aortic stiffness. It basically uses a bunch of techniques and some math to come up with a value representing aortic stiffness. So if we look at this graph, this table for the results from this research, and then we can see that in the placebo group, pre and post, for the MK7 group, the level of UC-MGP, it decreased, and this was very statistically significant. And this makes sense because by supplementing with vitamin K2's MK7, this helped to increase their vitamin K2 status. Therefore, their UC-MGP decreased. And now, if you look at the carotid femoral pulse wave velocity in the placebo group, pre and post, they gained pulse wave velocity, and this was statistically significant. And this represents the aortic calcification, which is just the normal age-related wear and tear, and it's just a normal part of aging. However, when you look at the MK7 group, this wasn't statistically significant. So what does this tell us? This tells us that pre and post, they were the same. We did not see this age-related wear and tear. This once again suggests a protective effect of vitamin K2 on the arteries against calcification. We don't see this age-related wear and tear. So For the efficacy in COVID-19, now this was a very interesting study. This was a December 2020 retrospective case series in Copenhagen, Denmark. And this was in 138 patients, so pretty small, aged 18 and over, with a new onset pulmonary infiltrate confirmed COVID-19 between March 2020 and April 2020. The researchers tried to find if vitamin K status reflected by UCMGP levels in these hospitalized patients compared to 140 population controls did it predict mortality risk. So this is what they found. They found that after admission, 43 patients died within 90 days of admission. And when they compared the levels between the survivors and the non-survivors, their levels of UCMGP differed significantly. Furthermore, the survivors had a blood UCMGP level of 877 picomoles per liter. And the non-survivors had a blood level UCMGP of 1445. So what does this tell us? This tells us that the survivor group had better vitamin K status because they had a lower UCMGP level. Remember that the lower your UCMGP level, the higher your vitamin K2 status is. Furthermore, when they compared the UCMGP levels between patients and controls, it was higher in patients, 1022, compared to controls. So this means that people that were admitted to hospital had lower vitamin K2 status. So then the researchers did a regression analysis and showed that the lower vitamin K stat levels are associated with higher mortality. This was after accounting for all the variables and using statistical analyses. So then the researchers made a Kaplan-Meier plot, and a Kaplan-Meier plot, what it tries is basically a statistic used to denote the amount of patients living after treatment. So if we just look at the very top line here, this indicates the line of patients that were admitted into hospital with the highest vitamin K2 status. So if we look at the lowest quartile here, it was less than 646. So this indicates the highest K2 status. Then these patients had the lowest risk of dying and the lowest mortality, which is very interesting. But once again, this was a small study, so I do want you to take it with a grain of salt. So now, what if we look at the safety of vitamin K2 as MK7? Well, in natto, there's 1,000 mcg per 100 grams of natto. So that's maybe 3 packages worth of natto. You can find them at like Asian superstores. And there were no adverse effects reported despite Japanese eating this for thousands of years. And in regards to the FDA, many studies have been performed with doses up to 45,000 mcg per day of MK7. And vitamin K2 as MK7 is regarded as GRAS, generally regarded as safe by the FDA. Furthermore, in animal studies, one-time doses up to 2 million mcg per kilogram. So if an animal weighs 5 kilograms, for instance, that would be 10 million mcg of vitamin K2 as MK7 that they would receive. And this has been given to animals with no toxic effects. Furthermore, in Japan, MK4 in the dose of 45,000 to 90,000 mcg a day has been used in the treatment of osteoporosis for many years without any reports of an adverse effect. Now, to explain why, this is due to the less absorption of MK4 and higher doses in the milligram range are used rather than the MCG range, which is used for MK7. However, there is a caution for all of this though, because if you take vitamin K antagonists, such as warfarin for example, as little as 10 to 20 mcg of vitamin K2, MK7 can cause a clinically relevant lowering of INR in 40-60% patients. So I found this in this study, and this was assessed by hematologists. So Therefore, I came up with the recommendation that in vitamin K for in terms of vitamin K2 in patients taking vitamin K antagonists, we should avoid vitamin K2 as MK7 in these patients because once again it can cause clinically relevant lowering of INR with just a very little dose. So, what about the cost and convenience of this vitamin K2 as MK7? Sure, sir. A lot of people have not even heard about it. Would you be surprised to hear that it's already on the market? Would you be surprised to hear that it's already in your local Shoppers Drug Mart? Would you be surprised to hear that it's already in all natural health stores? So if we just look at Shoppers Drug Mart, for example, they sell 3 different brands of vitamin K2. But interestingly, they're all packaged together with vitamin D. But it is important because in the very beginning of this presentation, I said that uncarboxylated osteocalcin is made by 125-dihydroxyvitamin D3, which was calcitriol. So it's very interesting. So they have 120 mcg of vitamin K2, 120, and 120. 120. And the price of them is not that expensive. Around $12 for all of them. But what is really interesting is that there's only 30 soft gels in this package. Now, if you look at what is offered by natural health stores, they have 120. And instead of 120 mcg, it's 100 mcg, which isn't that much of a difference. And it costs $18. So $18 for 120 versus around $12 for 30. Why is there such a discrepancy? And sure, there's no vitamin D3, but I don't think that just because you add vitamin D3, you have to increase the price so much. And it's also interesting, why doesn't Shoppers Drug Mart stock vitamin K2 as 120 as this form? Because it would be much more cost effective for patients to get this form. So personally, I think that pharmacists are in a very good position to help advise patients on vitamin K2. If a patient is looking for perhaps if worried about their bone mineral density, perhaps worried about their cardiovascular risk, perhaps worried about COVID, then vitamin K2 might offer some help in terms of these areas. Once again, you should take this as a grain of salt. And you should also make sure that the patient is not taking any vitamin K antagonists, such as warfarin, for example, because in that case, taking vitamin K2 as MK7 might lead to a change in their INR, which is something that we don't want. So, to recap the session, and what are the takeaways for the session? So, vitamin K is not entirely vitamin K1. Vitamin K2 exists. Vitamin K2 as MK7 is the most active form. K2 acts to carboxylate UCMGP and UCOC. K2 status is reflected by UCMGP levels and UCOC levels. And remember, less is better. K2 decreases bone mineral density lost to age. It allows less cardiovascular death and then less calcification events. Remember, the serious calcification events, but not the moderate ones. And it may decrease COVID-19 mortality. The vast majority of us and the vast majority of the Western world are all deficient in vitamin K2. It is already available in multiple stores, Shoppers Drug Mart, Natural Health Store, and personally, I think the pharmacists are in a very good position to advise patients of therapy suitable for them. And once again, I want to say that there is a contraindication for vitamin K antagonist therapy, and always be sure to find out if your patient is taking vitamin K antagonist before suggesting vitamin K2 as something that might be beneficial for them. Now, if there are also any Japanese people listening to this presentation, I want to say どうもありがとうございました。私に聞かせてくれてありがとうございます。Therefore, I hope that this was useful to you, and thank you for listening.